virtual academic program. So we are social connecting in the era of social distancing. That is our slogan. So today we have our session, how should I treat my patients following evidence-based medicine? And today our faculty is Dr. Karthick Rajmani, and he is the consultant medical physicist in the Department of Radiation Oncology, United Hospital. He is an old face in our country. He has been here for so many years, almost like our own native person. He will be talking on how we give whole breast radiation therapy. So I learned many things from him. You can tell that the radiation oncology, he's the gear in my professional life. Whenever I need to get slow, he just catch me from the back. So that is the only thing I can tell, that he is the person who really guide us and help us in our life. So, and our three overseas faculty, Dr. Mohammad Zakirullah, Dr. Sheikh S.K. Farid Ahmed, and Dr. John Conibier. Thanks to all of them for enriching us. And as usual, our patron and our inspiration, Professor M.A. Hai, sir. Sir, would you please say a few words to start the program?
Rahim. My dear participants, faculties from home and abroad, Assalamu alaikum. This item already we had three. Our today's paper is a very nice paper. It's literally presented by Karthick Rajmani. He's almost a Bangladeshi now, staying in Bangladesh for a pretty long time. Consider him as Bangladeshi, he can speak Bengali very nicely. So I think without delay, we should start immediately.
Thank you, sir. So thank you, sir. Regan, can you please mute everybody except the speaker and me, because I see some background noise. So the housekeeping announcement, the time is 90 minutes, presentation is 15 minutes, comments 15 minutes, this we all know. And the statistication of the participation is there, but something is new. There is a new announcement this is applicable only for non-faculty attendants. Sorry for the spelling. They are eligible for it. So if you attend a program, you will get 5 points. For every question you ask, you will get 5 points. If you want to volunteer for the hot seat, you will get 10 points. And if you volunteer for rapid fire, you will get 10 points. And if you volunteer for presentation, you will get 10 points. So if you can collect 100 points, we will give a gift from here. There will be multiple options. You can choose one of the gifts. It can be a gadget, it can be a phone, whatever it is. But once you get a gift, the bonus is over, then you need to start your account. So in the chat box, there will be a link. The non-faculty attendants are those, they may be student, they may be postgraduate, but they should be less than assistant professor. So they should register their name in the link to get the chance, because today already, if you join, you have attended 5 points. So you have achieved 5 points. So this is something new. So we will be needing a volunteer from the non-faculty presentation, because from next session, we will have a 5 minutes presentation from this non-faculty participants. And the next week topics is what is new for breast cancer in AJSSC 8th edition. So try to be a volunteer, because if you become a volunteer, you can present it, you will get 10-point bonus. So with this, now I will request Karthik to start his presentation. Regan, can you give the screen share to Karthik? And Karthik, now it's you.
Yeah, I'll take the screen. Yeah. Good evening, everyone. And just first of all, I thank the Oncology Club for providing me the opportunity to be part of this academic program. Today, I'm going to talk about how we give whole breast radiotherapy. Just, I'll try to cover from the simulation to treatment delivery. The rationale of the whole breast irradiation is once.
Karthik cannot hear you.
Okay, can you hear me now? It's better. Hello. Oh, just a minute.
Hello, Karthik.
Yeah,
I cannot hear you.
Okay, just a minute. Now it's fine.
Okay, fine.
Are we able to hear?
Yeah, it's okay. Fine, thank you.
Yeah. Hi, good evening, everyone. It's a pleasure to be a part of this academic program. I first of all thank the Oncology Club, to involve me in this part of this academic program. I know this breast cancer teaching program is going for a long time. My topic today is how we give whole breast radiotherapy. I'll try to cover from the simulation to treatment delivery. The rationale of whole breast irradiation, from the Lancet Oncology paper, after the radiotherapy after breast conserving surgery, really it reduce like 50% of the disease recurrence and reduce the breast cancer death by 1/6. So that we have a clear evidence of whole breast radiotherapy after BCS surgery, which has we have a quite good evidence that it can reduce the recurrence of the disease by 50%, as well as it can reduce the death by 1/6. Mainly I'll try to cover the in this presentation. I'll try to cover these are the topics I'll try to cover in this presentation. I'll start with patient positioning and immobilization. The position must be really considered, and according to the beam arrangements. Really, we need to give a close consideration, how your beam arrangement is going to be, and it is very important for the patients to be a very comfortable position as well as a reproducible position. Normally for the breast cancer radiotherapy, in our center, we try to use these are the three different emulsion lines: wing board, breastboard, as well as sometimes if for an if you have a pendulum, this we try to use a thermoplastic cast. Normally these are the patient positioning devices. You can see from the left to right, the wing board, breastboard, and breastboard with thermoplastic mask. Normally breastboard, there is a small issue with using a breastboard. Once you have an medium bore site CT scanner, ideally you require a large bore CT scanner, roughly around 70 centimeters, so that you can accommodate the breastboard. Otherwise, for a small bore or a medium bore, it's really difficult to accommodate the breastboard. I will just come back, what is the advantage of the breastboard, in the case of the breast cancers. Really, it has an, very comfortable position for the breast, with an arm can be rested in a comfortable position, then it can be comfortable, keep it in a comfortable position, and we can able to give an inclination angle to 10 to 15 degree. And if you have a large bore, we can extend this tilt further to 20 to 25 degree inclination, which is going to be really used for the breast cancers that we can see in our following slides. Wingboard is an quite comfortable, positioning device in breast cancer. Normally, in our center, we use a lot of wingboard compared to the breastboard. But in some certain cases, we really use the breastboard. But most of the patients which has a small and medium breast, really wingboards are good. And once you have a problem of if you don't have a wide bore CT scanner, obviously this is going to be a best choice for using the breast cancer for the whole breast irradiation radiotherapy positioning device. And if there are sometimes, we can use an VACLOC as wingboard combination also is possible. And we'll start with the patient simulation. Here, in my talk, I am just, I want to very clear with this, we are not going to talk about the nodal irradiation. We are going to talk only about the whole breast irradiation. Probably in our future talk, we'll try to include the nodal and the supraclavicular irradiation. So that just in this presentation, I'm going to just focus on whole breast irradiation. Normally, we start with the patient simulation. I know in developing countries like India, Bangladesh, we have a lot of problem with the infrastructure. Probably we don't have our own CT simulators. We don't have a conventional simulators. Most of the times we have to go with our manual planning. Okay, we'll start with the patient simulation and marking. If you take this as a whole breast, okay, normally we do a marking somewhere like this. We put in cranial borders somewhere around the second intercostal muscle or the head of the clavicle. The medial border is something about 1 centimeter away from the midline, and the lateral border will be something about 1.5 to 2 centimeters beyond the breast tissue. Just we have to give an enough flash so the respiratory motion will not just give a glance over your breast, so that you give an adequate margin to flash the breast. And the lower border somewhere around something about 2 centimeters from the inframammary fold. Yeah, I think this is standard margins, how much you do as a patient simulation marking. But again, when we go for an CT-based simulation, it's really difficult to differentiate the breast tissues and the normal tissues, so that really this marking up this wires really will help us. And you can see here there are two different ways of doing it. Some people try to mark the just only the field borders. In some situations, people mark only the whole breast. Some centers, I have seen, they do it both, so that they can understand the breast tissue as well as the field borders in the CT scans. And you can can clearly see, like, how the scar has been marked. Really, it will help for the boost treatments, and see the lumpectomy cavities clearly in the CT scans. Okay, again, just adding to the immobilization device, and normally this couch index rod, which is really very important, which can really reduce your rotation of the patient, which is in your direction, so that using any mobile cushioning device like backlock, sorry, the wing board or on breast board, using this additional indexing position, really it is recommended to use, so that we can avoid the rotation of the patient along the yaw direction. Our institution protocol, like, if you see in United Hospitals, basically for a small and medium breast, we always try to use the wing board. Once the chest wall slope is too high, I'll show you in the forthcoming slides. Like, we try to use the breastboard to make the chest wall flat. And if there is a pendulum breast, like, for a large breast, we try to use the breastboard with the thermoplastic mass, which will give, reproducibility of the pendulum breast much better. And during the CT simulation, it's very important, like, this is what we are going to take a snapshot on the particular day, and we have to maintain this for the entire 25 to 30 fraction, so that we have to give a lot of importance for the CT simulation. Especially, like, when you have to see, like, in the scanogram, you can see, try to keep the patient straight, hand position, like, you can try to see, like, both the clavicles are in the same level, and the patient is exactly centered. This can be checked with the use of the measuring tools in the CT scanner, and we have to make sure the patient is dead straight, and because this is how, like, we have to reproduce for the entire patient for another 5 to 6 weeks. And I will start with the 2D planning, because we have I as already told, like, we have a lot of infrastructure facilities like CT simulator and other things, so that I'll start with the manual planning, so that if you keep this as a border, normally what we can start with doing is, most of the times we need to exactly know our gantry angles to treat the whole breast. So that what we can do is, like, I think a lot of people has been practiced like this. Just I'll try to remain again. You can use an plaster of Paris, just in the center of the, like, from the superior to inferior border. You can take it at the center, and use some plaster of Paris or any lead wires, which can reproduce like in the same position. Once you take the contour of the breast, you can reproduce in the same manner, and you can put it on this paper, something like this. I will just come back, like, something like this. Okay, what here is, like, you can use a scale just to measure your vertical separation of the patient, as well as your this like, towards, if you can mark it out, you can see here A and B. You can get it from the scale, like, if you can put two scales here, or you can have an L scale, you can easily measure the distance. Like, this distance is around 19 centimeters. For an example, you can keep the vertical separation between these 2 points is around 17 centimeters. So that this, like, you can put this contour here, and just assume, okay, this is a contour overlaid here, and this is an right breast, so that we are going to give an medial tangential, and as well as a lateral tangential. The thing is, like, most like, like here, just I'm going to explain you how we can find out an exact gantry angle for particular breast, like, because every breast is not the same. Every breast, the vertical separation and the lateral separation is going to change, so that it's very important the gantry angle is not going to be the same for all the breast. So that if you want to do as a manual planning, like, what you can start with, once you know these two separations, the vertical separation as well as this, the separation part A, like, around 19 centimeters between these 2 points, then, like, which can be measured with your scale. Then using your Pythagoras theorem, like, a square plus b square is equal to c square, we can easily identify your tangential separation, which is c, which is, in this case, it will be 25.49 centimeters, or you can make it 25.5 to a round figure. Okay, so that we can identify a tangential separation using the Pythagoras theorem, a square plus b square is equal to c square. Okay, again, getting into the how to determine the angle of the like, for the breast patient, like, here we need to do a little bit of a basic max. Okay, like, for we know this the dimensions, like, the opposite is something about 17 centimeters and adjacent is 19 centimeters. So that from a basic math formula, the tan theta is given by opposite by adjacent. Okay, so that it is 17 by 19 centimeters. So that the theta angle, which is given by tan inverse, you can use an scientific calculator and put a tan inverse of this. It's just going to be 41.8 degrees. So that I know exactly this angle is going to be 41.8 degree. Why I want to show this is because when you use different separations, the vertical separations, which is going to result in a different gantry angle to be ideal gantry angles. So that for the lateral tangential angles, normally we are going to use around 221, as well as the medial tangential, which is exactly opposite of 180 degrees, such as 41.8. So that this is the easiest way, you can find the gantry angles for the whole breast irradiation. The other method, which is also an alternate method, which is also very simple. Once you have this dimension on your paper, which has been delineated, you can simply use your protectors, just check the gantry angle. Okay, then again, coming to the point, SSC or SAD technique. Like always, I prefer an SAD technique. As a physicist, it's very convenient. We can, if you want to treat in a large volume center, you want to have a larger throughput. SAD will obviously reduce your treatment time, because setting at one and just you can rotate your gantry from outside and you can treat the patient much easier. Okay, again, for this, what you can do is, if you want to go with an SSC technique, it's much simpler. You can go and put, if you're treating with a cobalt, just go and put this point, you can take the central axis and you can put the point, and you can take the separation of your breast, along this direction, and give an additional sufficient margin to graze the breast, the skin flash, around some 1.5 to 2 centimeters. And you can put in medial and tangential fields, and you can put in you put in 80 centimeters here for an linac. You can put in 100 centimeter here, and you can treat an SSC technique. For an SAD technique, yeah, you have to do a little bit of a little bit more calculations, so that once you have a tangential separations, you know how much you have to move to bring it to this point from this measurements, so that you can, especially you can bring it to this point where you can treat an SAD patient. So that when you try to give a feel, you can put a feel. But again, the dose point of prescription is very important. You have a tangential separation of 25.5 centimeters, and you try to treat a feel like this, and always you cannot prescribe at the maximum tangential separation. You have to go with if you, for in this instance, you have a central axis of around 16 centimeters and your maximum tangential separation of 25.5 centimeters, you can take the 1/3 of the breast separation, and you can normally somewhere around 18 centimeters, so that you can avoid the hot spot in the apex of the breast. And there is a problem when you try to treat with an open beam for a whole breast irradiation. You can see in this case, you can see that if you try to treat an whole breast with an 4 MeV beam, you can see you're giving an 50 gray in 25 fraction, you can end up of an, you can see the hotspot of an 60 gray here, and which is something about 20%, and you can see here something about 10% volume is more or less covering the whole breast. Okay, obviously, using an open beam will give a lot of hotspot. Ideally, we need to use an appropriate wedge angle, whether it's a cobalt or it's a linac. Better to use an hard wedge, which you can see here clearly. You can see the homogeneous distribution around the breast target. And here also, we simulated the same situation. We try to treat an open beam as well as a wedge beam. You can see the hotspot of 110% is more or less covering your 50% of the whole breast. Whereas once you try to use an wedges, whether it's a hard wedge or a non-physical wedge, like an enhanced dynamic wedge or any Omni wedge or from Electra or enhanced dynamic wedge variant, whatever it is, especially these non-physical wedges are quite good to use in the asymmetric fields, so that you can see a very homogeneous coverage around the breast target. So that it's always desirable to use an open beam is using a wedge beam compared to an open beam, which can reduce. And especially when you go for a hyperfractionation, we have to be really careful on the amount of the hotspot which is on your breast tissue, because the dose per fraction is it's not the conventional one. You're going with 2.7 ray per fraction, which is quite high, and which can really going to damage your cosmetic of your breast tissue. And the one more important thing is, you need to understand always when you do a 2D manual planning, we always go with the central axis. We go with the center plane, which is where your central axis pass through. But the problem is, when you don't give an enough collimation, we simulated this scenario in our treatment planning system. I'll show you the DVH. Like you can see the amount of a lung and heart come inside the treatment field if you don't give an proper collimation. So that this is an, with an ideal collimation. And here, if you don't do collimate, you can see like something about 50% of your heart is inside your radiation field, and enough part of a lung is coming. Here is where the part of using a breastboard comes. Once the breastboard just push this field really flat, yeah, normally we can avoid this collimation if you can if you can really use your breastboard effectively. In this case, if I don't do the collimation, for an example, you can see the amount of the hard dose without collimation, proper collimation, and you can see the amount of an hard with collimation. You can easily see the amount of a difference, how much you can get. Like if you don't do the proper collimation setting, you can really going to expose a lot of heart inside the whole breast, during your tangential fields. So that appropriate collimator angle is very, very important. And again the problem is the amount of lung involved in the tangential fields. Normally this is from a paper, we know, like especially if you are include 1.5 centimeter of a central lung distance, normally we are going to irradiate some roughly around 6% of your normal lung. When you try to include around 2.5 centimeters, around 16% is going to be inside your radiation field, and the 3.5 centimeters your central lung distance, which you can measure here, which is going to be somewhere around 26%. So that we are very safe when you can use 2 to 3 centimeter of a central lung distance, and we can expect an radiation amount is less than 2%. And once if it is more than 4 to 4.5 centimeters of a central lung distance, we'll end up the risk is more than 10%. So that it's really very important to, when you do a manual planning with a simulator or something, the amount of a central lung distance is really need to be noted, and it should be within 2 to 3 centimeters to reduce your radiation amount is risk percentage less than 2%. Just before getting into the little bit of the planning part, I just want to give an some demo case from the RTOG guideline. Like this is a case like of in stage 1 T1C and N0 and lumpectomy done, sentinel node biopsy done, and there are surgical clips at the lumpectomy site, so that you can clearly see the lumpectomy cavity there, and there are external markers, wires, and there is a scar over the lumpectomy cavity. And the important thing here, why I want to show this contour is, as a physicist, if you don't do the best contour properly, I have a big headache. With my, experience, the one of the difficult planning, like what I encounter is the breast planning. It's really difficult, and you need to spend a lot of time to get a very homogeneous distribution. It's not, it's comparatively the prostate and other sites like breast planning, you need to give a lot of time to get a very homogeneous distribution, especially the hyperfractionation where you need a very homogeneous PTV distribution. Really, we need to work hard to get your have a very homogeneous around the PTV target. Okay, so that the contour normally, compared to the Western countries, our subcontinent, like in India, Bangladesh, like Pakistan, we always overdo the breast contour, and it's always difficult for an as a physicist for me, it's going to be difficult for do and proper planning with reducing the dose to the lung and heart, so that appropriate contouring is very important to obtain and very successful treatment, without an higher toxicity to the OARs. I just have to go through these slices. You can just see, always there are one thing I want to make sure, just always try to avoid this pectoralis major and pectoralis minor muscle. Okay, you can see here, just try to avoid and just try to take only the breast tissue here. And always we put the this markers in the CT scan just to make sure, because it's very difficult to differentiate a breast tissue and a normal tissue here. So that this wire, the breast wire, where you put it on the CT simulator is really going to help us to delineate the breast. And the other important thing, we have to remember is, don't try to take the intercostal muscle, okay, between the ribs here. Okay, it is very important. Try to restrict your CTV just above that. Don't try to delineate your intercostal muscle, so just try to keep your CTV just like that. And here you can see this, and always tell your surgeons to put, and here in this case, we can clearly see the lumpectomy cavity, but it's not in the same case. We can see the lumpectomy cavity very well. So that, most of the times when you send a patient for a surgery, request your surgeons to put clips in your surgical cavity, lumpectomy cavity point. Really, it will help you to when you do the breast planning. Okay, so that it's in this case it is very clear. You can see the breast tissue is well contoured, and just to try to avoid the intercostal muscle here, and you can see clearly, and it's a very simple case to delineate the breast. Okay, like in this case, as a demo case, it's really good. Okay, this is just the main point is just try to avoid the intercostal space. That is the one thing just I want to make sure here. And if you see the sagittal weave here, like if you go with the traditional field, if you the field margins just 2 centimeters below your intramammary fold, and if you see the inferior superior border is just on the second intercostal muscle, so that it's exactly matched with your traditional landmark based treatment, so that when you do contours, so that your sagittal weave will you can go to the sagittal weave and you can exactly see whether you are within that landmark borders. And again, regarding the target volumes, after that, when you give an PTV margins, obviously we add an PTV margin somewhere around 5 millimeters to 6 millimeters, according to the institution protocol. And always try to crop your PTV from the skin somewhere around 5 millimeters. It's very important when you evaluate the PTV coverage in your DVH. If you try to keep the PTV in the skin level, it's very difficult to have a proper coverage, and documentation of the PTV will not be that great. So that the RTOG recommends, you try to crop the PTV from the skin 5 millimeters for the evaluation of the PTV, so that they used to call and terminology PTV about that is called evaluation. Always try to crop 5 millimeters from the skin. Most of the treatment planning systems are not very accurate in your skin along the first 1 to 5 millimeters, which most of the times it's always underestimated. So that be careful when you do high-end plannings like IMRT. When you have don't try to try to build it up more on the skin, and we'll end up in a higher skin toxicity. Okay, this is an tip, just I simulated and same scenario. I did an cropping of just 3 millimeters here, and I crop on 5 millimeter here. You can see really if you don't crop the PTV from the skin, really you can see this DVH is not really good, and when you document this PTV, really you will end up in a lot of underdose. When you try to document, when you have a 5 millimeter crop, you can see it's having much better coverage, so that it's really according to the RTOG guidelines, when you try to go and see the PTV homogeneity, it's going to be much better when you don't crop 5 millimeters, and if you crop the 5 millimeters. And another important aspect of when you go for the 3D based planning, the consistency of a hard delineation is much more important. Most of the times we confuse the we started there is no consistency where to start the heart, inferiorly, from the superior to inferiorly. So just I thought I can give you a guideline how you can start the heart, where you can start where the pericardium starts and where the heart starts. Normally the pericardium exactly starts just 1 or 2 slides from the aortic arch. Okay, so that you can see the aortic arch here. Okay, so that you can start 1 or 2 slides just above that, you can start the pericardium. But when you want to start the heart, that's where your the pulmonary artery trunk, you can see here when it's bifurcate, this is the pulmonary artery trunk. Okay, when you can see then where it bifurcates, that's where the heart delineation should start. That's where the pericardium as well as the heart join together. So that you can see here this the pulmonary artery trunk here. Okay, the next slide, it's get bifurcated. That's where the heart should start delineating. Okay, the other thing is you can if you want to delineate the different different this pulmonary artery, left atrium, right atrium, and left ventricle, you need to have a contrast CT, and and we need to have a high speed CT to delineate this volumes, and we need to have really a contrast, otherwise you cannot differentiate this pulmonary artery and other structures really well. So that you can see the left ventricle, pulmonary artery, and clear. So that you have to make sure where to start the heart and where to start the pericardium, and that's more important. That's the only thing just you want to start, so that you have a consistency in your delineation of the heart. Just this I followed the RTOG guidelines here. I just put the slides of the RTOG guidelines. Okay, regarding the treatment plans, okay, when you try to give an when you don't have an option of an asymmetric field options, Like when you try to treat in a cobalt or in Linac, which don't have an asymmetric field, you always try to give an open beam, and where the divergent beams goes towards the opposite, like which can pass through your heart as well as the lung. So that a small tilt of 3 to 4 degree, which can avoid your beam divergence. You can see a small degree of 3 to 4 degree, which you can make your dose distribution perfectly straight. For example, just I am showing here, okay, just we can put a two fields, and you can see that there is a small, divergence playing here. And once you tilt the 3 to 4 degree, you can just avoid a lot of heart as well as the lung volume, which you can make the divergence. If you are using a symmetric field also, you're able to reduce your amount of a divergence by just giving a 3 to 4 degree tilt. And you can see the difference, obviously, it's going to have a much difference here, which by avoiding the divergence, we are able to just save something about 10, if you see the V20 of an heart, which we can reduce something about 5 to 7 to 8%, which is substantial. So it's a small gantry tilt can avoid your critical structures much more better way. And the important thing, how you read a DVH. Okay, just I'll have a slide to show a DVH. In this case, if you see the V10 volume, how you define the V10 volume here is, you can see the volume. This is in the x-axis in the gray and the y-axis in the percentage. The volume receiving 10 gray at this particular point is 75%. Okay, so that you have to divide as two components. One is this entire area from here is the 75%, and remaining this area is 25%. So that how you can explain this, the volume receiving 10 gray is 75% and more, and the volume receiving 10 gray is 25% and less. So that's how you define your volume. So that in another example, like if you want to talk about a V20 volume, here is something about, we define at this particular point V20 is 25%. But if you want to define the volume receiving 20 gray is 25% and more, and 75% of the volume of the lung is receiving 20 gray and less. So that this is how you have to divide and read the DVH. That's very important to understand this. So that asymmetric fields are often great options when you try to treat a whole breast irradiation. So that whenever you have an asymmetric field option, always try to use an asymmetric field just to try to avoid an divergence, which is going to help a lot of things. Okay, and CT-based planning really helps because here we can see the evaluate the plan quantitatively and qualitatively. We can record the dose of all the OARs. We can try to see the PTV coverage. We can optimize the treatment plans to improve the dose homogeneity. So that always CT-based planning will be the best choice, like when you go for a whole breast irradiation. And adding that, wedges and field in field techniques, here, I can just contour an hotspot here and try to see and put a field in field. Like you can just see a field in field technique here, which can reduce your hotspot in their PTV target, and it can really make your PTV very homogeneous. And when you go for a conventional fractionation, it's very important to understand your dose criteria. Okay, so that for an ideally, we should have a 95% of the whole breast PT level should receive 95% of the prescribed dose, that is 47.5 gray. And sometimes, it's very difficult to achieve. These are ideal situation, but still we can achieve 95% of the whole breast will receive more than 95% of the whole breast dose, which is 45 gray. So that in any case, you need to cover your whole breast with 45 gray when you go with a conventional fractionation of 50 gray and 20 fraction. And if you go to an OAR dose, then I will try to specify two things. Obviously, like when you go for ideally when you go for a hard dose, try to keep your mean dose less than 4 gray. That's very important. And and try to keep your 5% of the heart volume less than 20 gray or less. That's very important. And if it's not possible, try to keep at least 25 gray or less. That's very important. 5% of the heart volume should not receive more than 25 gray or less. And for the lung, I think if you're able to keep your V20 less than 50%, but otherwise you can keep your V20 somewhere around less than 20%, which is ideally good. I think this paper is one of the important paper which can talks about the coronary events, and which is published in the New England Journal of Medicine. And according to this data, I think we given the heart tolerance of 4 gray tolerance. And we need to understand every 1 gray we increase of the heart mean dose, which is going to increase your the coronary event by something about 7.4%. That's very important. Instead of a 4 gray, you are trying to give a 5 gray mean dose to the heart, which is going to result in an something about 7.5% incidence of a coronary event for any particular patient. And which is, this is a big study, like, this is a lot of the patient enrollments around 200, 2000, like 2100 patients. And it's a large group of study which has been treated from 1958 to 2000 in Sweden and Denmark. And obviously, if you can read this paper, you get a lot of an idea about, how the cardiac doses has been derived. The other paper, like, which done in US with a database, like, which they've taken only their patient which age more than 66 years, and they included somewhere around 63,000 patients. And if you can see, like, these all patients are very old patients, the age of above 66. And if you can see the amount of breast cancer death and the the cardiac incidence, like, if you can see after 8.5 years, the amount of cardiovascular death is much higher than the breast cancer death. So that we need to be really careful, like, about the cardiac toxicity when you go with conventional or hyperfractionation. We need to be very clear. Otherwise, you're going to end up, the patient is going to be cured from the cancer, but you end up with a lot of cardiac toxicity and going to die with a disease-free, and the patient is going to die with a cardiac toxicity. And it's not only the mean heart dose. Now a lot of publications are coming up, like, it's not only, because most of the times if you see the tangential field, not the entire heart is coming inside the picture. Most of the times, so there are new studies which is coming up which shows this LAD, the left anterior descending artery, the left ventricle, the myocardium. These are still, it's a long way to go on, with which doesn't show any clear results. But in a small scale of study with 200 and 300 patients, still they are not trying to find out this doses to the LAD, left ventricle, and myocardium, which is going to affect more rather than the mean dose. Instead of going to the mean heart dose, we need to be very careful on these structures, which is going to give a lot of toxicity to the heart. And this is another paper, which shows an coronary stenosis were observed when an left anterior descending artery which receive a mean dose of more than 20 gray. So that now I think from the mean dose concept, we are just going towards a particular different component of an cardiac, the heart, we have to trying to evaluate, how that doses to these structures will going to give an cardiac toxicity. And the boost value definitions is also, it's we need to give an additional CTV, if we are able to dilate the lumpectomy cavity, and always try to give an CTV margin, and we go for the PTV margin. And again, it's the same thing. You need to crop 5 millimeters from the skin just to make sure you can document the PTV properly. The boost techniques normally we can be electron, it can be photons, it can be an intensity modulator radiotherapy, or you can have an brachytherapy in it. But when you want to choose an electron and photon, it's very important. Normally, if you have a deep-seated tumor which is more than 6 centimeters, always you opt for a photon boost compared to an electron boost. Always, if there is any tumor which is less than 6 centimeters, you can go with an electron boost. And before, for the energy selection of the electron, it's very important to understand the PDD parameters. Here, just right now, I will emphasize on two parameters. One is RT, which is the therapeutic dose, and RP is the practical range. Okay, so and Dmax is obviously the 100% where it emits. And if you can see, this is an electron parameters. Normally, when you try to choose electron energy selection, normally if you have a depth of something about your tumor is at 4 centimeters, you have to just the maximum depth of the tumor is 4 centimeters, just you multiply it by 3, so that your therapeutic dose is given by energy divided by 3. That is your therapeutic dose, that is R85. Okay, so that you have a tumor at 3 centimeters, you have to multiply by 3, so that 9 MeV will be an ideal for your that particular case. And Dmax is given by energy divided by 5, so that if you are using an 10 MeV electron, that your Dmax is going to be 2 centimeters. If you're using an 12 MeV electron, it is going to be a 6, you divide by 5, 12 divided by 5 will be your Dmax. And the practical range is a very important concept, where your critical section should not come in the practical range, so that you divide the energy by 2, that is going to be your practical range. So that, for example, if you take your 9 MeV beam, if you want to see the therapeutic range, R85 will be energy divided by 3, that is 3 centimeters. And your RP will be energy divided by 2, that is 4.5 centimeters. And if your Dmax should be energy divided by 5, that is something about some 2 centimeters. So that this is very important to understand when you try to prescribe what kind of an energy you use for the breast lumpectomy cavity, so that you can use these equations to find this particular energy. And another important thing is the obliquity of an electron beam is very important. Like, if you don't give an particular, you have to go with perpendicular to the beam. Otherwise, you are going to end up in giving a lot of dose to your critical structure. So that appropriate gantry angle is very important to give an electron boost to avoid the critical structures. Like, unnecessary to give a doses to their lung in this particular case. And if, for an example, if your obliquity, like the angle of incidence is not perpendicular, if you have something about 45 degree, like, you can see the amount of a hotspot which increases something about 30 degree, 45 degree, 60 degree, you can see 75 degree, the hotspot increases more than 120, 130% in there itself in the tissue. So that it's going to be really too much of a gradient there. So that proper angle of an electron beam is very particular, that particularly important. When you go with treatment delivery, EPIT can be also used, and really it can be helped to find your central lung distance, and you can see the flash distance, and you can really see, like, your upper margin and the lower margin clearly, like whether you are, so the treatment delivery can be checked with EPIT. And if you go with a KV-KV match, like, obviously you can delineate in the treatment contour, you can do the sternum as well as the carina, which will be helped in the KV-KV matching in the orthogonal fields. And obviously delineating the ribs, like, in the KV structure and overlay over the DRR will really help to match much better, and will save a lot of time when you do the KV-KV matching. And like cardiac sparing is very important nowadays. We have an advanced technique, like, this paper we published from our center, and how you can do a cardiac sparing with a deep inspiration breathe out. So that if you do a normal breathing, we can ask the patient to take a deep breath and hold it for something about 20 seconds. Like, during that time, we can do a beam on. Both the Electa as well as variant have this options. Like, this is you can see the picture here. Like, when you have a deep breath, this is a deep inspiration breathe hold scan, and this is a free breathing scan. You can see, like, once you have a deep breath hold, the heart is totally away from your tangential field, and really you can spare a lot of, like, in a heart when you do a deep inspiration breathe hold technique. And if you go with the DVH, obviously you can see the amount of an like advantage of, if you do an DABH, you can really reduce your heart dose compared to the free breathing scan. We can reduce much as possible. This is a difference of a free breathing and DABH, what the data we published. You can really reduce your V20 volume more than 100% can be reduced, and deep inspiration breath hold really can help reduce your cardiac toxicity. I have some few slides about the hyperfractionation whole breast. Like, these are the 4 studies. Normally, we talk about the hyperfractionation, which has some 10 years data. And all are, like, most of the times you can see this, the important thing is the outcome of all these studies are favorable for hyperfractionation. But one thing you need to be very careful is, these are done with an, particular criteria for the OAR target doses. So that, this, if you go with this protocol, like, we try to be very sure, like, heart mean dose should not receive more than 3.2 gray. Like, if in the conventional fractionation, we can give a mean dose of 4 gray, but if you go for a hyperfractionation, we have to keep the mean heart dose less than 3.2 gray. That's very, very important. If you're not able to achieve this OAR criteria, really, we have to think, like, whether you have to go with an hyperfractionation or not. Otherwise, like, what is going to happen is the patient is going to be cured from this cancer, but he's going to be, because most of the cardiac toxicities are going to be late, which is something about 8 to 10 years, and really we're going to lose the patient because of the cardiac toxicity. And lung, the same way, like, if you can see about the V20 volume or V16, especially for hyperfractionation, has to be less than 15%, and V8 and V4 should be 35 and 50% respectively. And the do's and don't-dos in hyperfractionation, we need to clearly understand. 2D manual planning should be discouraged due to the lack of, we cannot document the OAR doses, and we cannot assure the PTV dose homogeneity. So that, we, like, it's discouraged when you do 2D planning. And planned homogeneous is very important. And PTV coverage more than 105 should be as less as possible. And volume receiving 110 to the PTV should be ideally less than 0%. The heart mean dose should be less than 3.2 gray, and ipsilateral lung volume V16 should be less than 15%. If you're not able to restrict the OAR and PTV homogeneity, I think better to shift to the conventional fractionation. So that, the patient is cured from the breast cancer but died of cardiac toxicity. So this is what's going to happen when you go with a hyperfractionation, when you don't try to keep your OARs, like especially the hard dose within the tolerance. And again, when you want to go for a higher, like, techniques like, deep inspiration, breathe hold, and other techniques, be careful. Like you spare heart, lung, and everything, as well as you spare the tumor. Okay, thanks. I think that's it. Amba, your voice is like muted.
Well, unmute karo.
Yeah, Karthik, thank you very much. You have done a wonderful job, and you have covered more than what I asked for. So I think there are some questions.
Yeah, sure.
So first question is from Altaf Hussain Riyad.
Okay.
So please unmute yourself and ask the question.
Thank you, sir.
Yeah.
I have two questions.
Yeah,
one
sure.
is there any role of prone position in whole breast radiotherapy? And
Okay.
second question is, if there is no surgical clip or any marker placed in the lumpectomy cavity, then what we could do in case of boost?
Okay. Okay. Thanks. I think it's a nice question. First thing, I will go with the prone position. I deliberately I didn't take the prone position in my presentation, because see, like, when we treat like, in Bangladesh or any so, like, developing countries like India and Bangladesh, most of the times we go with like, the whole breast. Only whole breast is a very limited case. Like, we go with something about 10 to 15% of the cases we go for only whole breast. Most of the times we treat supraclav and axilla, and like only you want to treat with the whole breast, yeah, you can think about prone position. But as a physicist, I feel the prone position is not a very reproducible position. Okay, and always I prefer as a supine position. Really you can see things like, in a prone position, if you see the shadow of the beam also without any imaging system, it's really difficult. So that I prefer the supine position compared to a prone position. Second thing, you asked about the markers. Okay, the lumpectomy markers, like, if there's a scar, if you don't have any incisional markers, always you have to blindly go with your scar marks. Okay, so that that is the only option. That's the only option. We have to go with the scar marks. Okay.
Okay. So we have another question from AB Mannan. How we can avoid hard dose in 2D planning?
Oh, okay. See, the thing is, like, in the 2D planning, really, we don't know, like, where the heart is underlying. Whether it's like, some patient, it's very close to your chest wall. Sometimes it is very away from your chest wall. Really, that's why, when you go for the 2D planning, we really don't know about the OR doses. That is the main disadvantage of 2D planning. And especially when you go for hyperfractionation, don't try to do it 2D planning, because we have no clue, like, what the hard dose, because sometimes I show you in my slide, if you don't do proper collimation, your 50% of the heart is going to be inside the treatment field, which is going to end up, the patient is going to, like, within 8 to 10 years, the patient is like, there are 50 to 60% of the chance the patient is going to die of cardiac toxicity. Okay, so that, be careful when you go with 2D planning. Really, we cannot do much about the heart, because we are not able to see anything. Like, we have to be very careful.
Okay, so there is another question from, I think, Dr. Ali Nafis. What is the reason of this blackening during radiation, and how can we prevent it?
Okay, it's a very interesting question. I thought of covering it. We found in our center, like, we found there is a big role of, chemotherapy is a component in blackening of the skin. Okay, like, there are some studies, which shows docetaxel. Some people use docetaxel, which has a very big impact of, skin blackening, as well as, chest wall, too much of a chest wall radiation. Otherwise, sometimes when like, the separation is too much, and when you try to treat with cobalt beams, like, we can find some skin reaction, not always, but I feel chemotherapy has a big role when you have a skin toxicity, especially on the skin surface.
So, any more question? Yes, I think Lima has a question.
Yeah, you can unmute it, please.
Please unmute yourself, Lima.
Okay. So thanks, Karthik, for your nice presentation. And you have very nicely shown how to fix the angle manually by mathematical calculation. But when we do the X-ray simulation, one thing we need to make sure that the central lung distance will be less than 2 cm. So by simulation, we first ensure that the central lung distance is less than that, and then according to this, we fix our angle. So when you do this mathematical calculation, how could you show that your central lung distance is less than you expect?
No. See, first thing you have to do it is you have to appropriately measure the gantry angle. Okay, then by using your lateral fields, you try to cover the amount of a lung you use it. Probably you have to go in the other way around. First, you need to identify your appropriate gantry angle. Okay, then you take if you have a conventional simulator, take an X-ray. Okay, see how much of a lung is involved. If it's 2 to 3 centimeters, it is fine. If it is 4 to 5 centimeters, try to avoid your field towards that direction. Okay, that's I think that will suffice. Your
so only this graphical calculation, it can give me the idea about the CLD. We have to take an exposure of X-ray.
Yeah, obviously you need to do it. Otherwise you're not able to find the CLD, because in 2D planning really it's not possible to find anything. You need to do an X-ray.
And another question, in a 2D planning, you put your medial border 1 centimeter. And generally put the midline because we want to encompass the whole anatomical line, and we think that if we put it 1 centimeter away, the lung distance will be more to cover this. So unless we want to cover the internal memory, we just put our medial border to the midline, not 1 centimeter away. I want to a comment from you, to know a comment about this.
Sorry,
midline or 1 centimeter away from the midline.
See, conventionally, when you go with, especially, I given 1 centimeter margin, because when you go with cobalt beams, okay, the penumbral margin itself 1 centimeter. Okay, that's where we need to be very careful. Okay, so that if you're treating with Linac also, you need to think about something about 6 to 7 millimeters of the penumbral margin. Okay, so that especially if you're treating with a cobalt, obviously I will ask to take 1 centimeter.
So considering that.
Yeah, if you're going for Linac, yeah, you can reduce a little bit more. Okay, it's a safety margin. That's it.
Yeah, I think Karthick, one thing is there. It is the contouring and the beam margin. Yeah. You can take a 1.5 even 2 centimeter when you are doing the contouring, but when you are putting the beam angle, you need to consider the penumbra to cover.
Yeah, right. That's what I want to tell.
That was the conventional planning margin he showed. The 1 centimeter.
Yeah. That's true. Yeah.
So, any more question? Okay, there is a question from Nusrat. Can you unmute yourself, Nusrat, and ask the question? We prefer that. Nusrat, unmute yourself, identify who you are, and then ask the question.
Sir, Assalamu alaikum. I'm Dr. Nusrat from NICRH. I want to know that to save our to reduce our cardiac toxicity in case of breast conserving surgery, which one is preferred, hyperfraction or conventional fraction?
See, that's what, if you do a CT place planning, if you're able to bring your heart mean dose less than 3.2 gray, you can go with hyperfractionation. There is no problem in it. Okay, like if you're not able to do it, your heart dose, the mean heart dose is something about 4 to 5 gray, I think better to switch it to conventional fractionation. Okay, that's as simple as it. If you're able to do it, if you're able to reduce your heart mean dose to 3.2 gray, then it's fine. Otherwise, yeah, you have to really think about going for hyperfractionation.
Okay, thank you very much.
So I think
I have a question.
Yeah, please.
Karthick.
Yes, Taposh.
Yeah. Karthick, do you recognize me? I don't know. I have met with you 2 or 3 months back in the United States about lung radiation, radiotherapy planning of lung.
Okay.
Thank you very much for your very nice presentation. I will just I'm working with cobalt machine in Chittagong. There are sometimes there are patients with a fungating, huge fungating mass, do not respond to any type of chemotherapy. We sometimes give the palliative radiation.
Okay.
How, in which technique we should give this palliative radiation? Is it
with cobalt?
medial or which profile? Medial lateral tangential or anteroposterior?
See, like, when you say, like, there is a fungatic growth in the surface, probably it's a T4 disease, right? Probably, like, I think, see, like, the only thing is, yeah, like, you can, like, sometimes you think about it's a palliative situation. If it's not a radical setting, so, like, yeah, like, you can go with a tangential field, rather than going with a single field, so that, you'll have a homogeneous distribution around that. Otherwise, sometimes, you will end up in giving too much of a dose to a lung, and, you will end up in too much of an acute toxicity in the lung. I prefer to have an homogeneous distribution. What are the things you do? Try to make it as homogeneous as possible. Okay, that's more important.
Will you prefer a bolus there?
How much dose?
Obviously, like, there's a skin fungating, you need to give a bolus there. Okay, like,
How much dose?
yeah, you can go with 1310. If see, like, yesterday we started a patient, I think probably Dr. Kamal patient. I think there was an, we had an, like, bleeding in the breast, like, it was a T4 disease. We gave it a 1310, like, like, just in hemostatic RT, you can do that.
We sometimes give the 400 in weekly dose.
Yeah, you can do it. Like, there is no harm in it, but, make sure, you are giving as homogeneous as possible, and you have less critical structure outside. Okay.
So any more question? I see participation from Sylhet also. Yeah.
Yeah.
Question?
Me, Lubna.
Lubna, please.
Yeah. So about electron boost of the breast, sometimes when the surgeon puts the clip inside, is most of the time we see that is near to chest wall, but the tumor may not be there. So, and the imaging sometimes may not be with us to look at reflect the energy of the electron beam. So in this situation, my question to you also. So what should you do?
Well, Karthik, will you try to help me, or you?
So, okay, you don't have you don't have an imaging. Okay, that's the thing, right? You only have a scar mark, and like, the only problem here is, how you calculate the depth of the like, where the cavity ends. That's where the big question. Like, if there is some surgical notes, like, how deep it is and which lobe it is, that is going to really help. But if you have a clear data, like, something about the depth is something about 3 centimeters from the skin, like, you can easily choose the electron energy, and we have to blindly go with the scar mark. There is no other option if you don't have an imaging. If you don't have an imaging.
If it was me, what I'm going to do, as it is electron, I'm going to take a higher depth. So at least I take a plain X-ray, as Karthik say, to make an assessment of the depth. And as I don't know the real measurement, so I will try to take the whole length to cover, and then I will select the electron energy, because it is better to cover it than to miss it. Yes, Farid want to make a comment.
Unmute first. Can you hear me? Karthik, excellent presentation. Congratulations.
Yeah,
just to contribute, to complement the answer Kamal Bhai said, which is absolutely accurate. The basic principle for any breast conserving surgery is you excise from skin down to chest wall muscle. So there won't be any tissue left. And it doesn't matter whether if it is close to the chest wall, or if it is in the middle, or if it is in the anterior part of the wide local excision specimen. Because when it comes to excision, we go straight from skin down to chest wall. And when the radiotherapy is given in different angles, when you collimate it, you should be able to cover the whole area. And when you talk about boost radiotherapy, obviously it's a very good practice, which is routinely we have to practice, and we do that even in Bangladesh as well. We put clips either on the edges of the excise on the cavity or on the chest wall, at least 4 corners and 2 in the center. So I don't think it should be a big challenge for any radiation oncologist to give boost radiotherapy, even in the absence of not knowing that precise information about the depth of the lesion. Is it a fair comment?
Yeah, what I was telling, that it is better to know the depth, but if I don't know, I take a higher length to cover the whole depth. Okay, so there is another question. Dr. Debraj Chakraborty, would you please unmute yourself and ask your question?
Sure, sir. Namaskar. And Dr. Debraj, I had a question. In 2D radiotherapy, do you use bolus in case of breast carcinoma? And if yes, then what protocol do you follow?
Okay, like,
Is it for whole breast or
mastectomy? Whole breast radiotherapy.
Okay.
Whole breast, see, there is no indication of bolus, but see, there are some areas where if you get a tumor which is very close to your skin and there is a skin infiltration is being proven, okay, then that is the case. It's very rare, probably for an T1 case where you're giving an only whole breast irradiation. If there is a skin infiltration is there, like that's the area where you think about a bolus, and no need to do it for the whole breast. Just you can try to keep only to that area, like where there is an skin infiltration, just to try to keep the bolus only to that area.
Okay, in case of post-mastectomy radiotherapy, what is
I think if you see, like just all irradiation, electron is one of my favorite preference. But if you don't want to use electron and you want to give a photon, obviously you need to use the bolus. Probably I think in probably in a further academic session, probably we have a plan to add the mastectomy cases in our presentation.
We will have a full session on PMRT. There we will have some more discussion. And today, intentionally, we have avoided nodal radiation.
Right.
That will be a separate session. So I think we can move to our next session. It would be, if we continue, it will be more on 1 hour question, I'm sure. But we have a limitation of time, so we are going. And so we are still waiting for a volunteer.
Kamal bhai, one thing I want to just tell you, like we need to be a little bit more particular about the hard dose, because see, now hyperfraction become a very common practice in Bangladesh. Okay, and the thing is, and the follow percentage in especially like India, Bangladesh, it's more or less the same. Like we have something about less than 20% of our follow. Like 80% of the follow-up we miss the patient. Most of the times we with my knowledge, our follow-ups are less than 30, like something about 20 to 30%. Okay, and really we don't know what is happening to this hyperfractionation patients. Okay, so that really we need to keep an eye of this cardiac main dose, like when you try to practice this hyperfractionation, and we need to be really careful because we don't have enough follow-up and we really don't know, like we are losing the patient like that.
Yeah, Karthik, what I want to say that not follow-up. The dangerous part is we don't have any outcome data. Even we are following up the patient, hardly we are checking towards the lung, heart. So we don't have any outcome data, so we are not very sure about what we are doing.
Yeah.
So I think this is going to start. Yeah, Zakir.
Thank you very much. I think it's a fantastic presentation. I learned a huge amount of things. But one thing, I'm not sure whether you have heard or have seen a randomized control trial came out about this boost radiotherapy. I haven't seen myself, but I've heard in our MBT meeting that the benefit of having boost radiotherapy has got no real survival benefit or anything like that. So they're probably going to omit boost radiotherapy in future. Any comments about that? John
Sir, actually, I think the Canadian studies probably they're not given any boost. I had, but still, sir, as a medical physicist, I don't normally, I don't see any problem, because as an oncologist, they have to take a point, call whether they want to give a boost or not. But still, there is no clear evidence so far. Probably there are studies coming up, but so far they most of the studies shows they want to give a boost.
Yes, I mean, that's what I'm just saying. But I mean, as I said, it's just I learned from MDT, recent MDT, they're avoiding to do any boost now because there's a big evidence that it hasn't got any benefit, survival benefit or anything like that. So, yeah, I think Farid would like to add as well. John Conivera, he wants his comment as well. Farid,
yeah.
So I would say, thanks. So for local control, though, we still give boosts for high-risk patients, so triple negative, close margins. So we do still select young women under 50, yeah. So, and also for DCIS as well, for similar circumstances. But you're right, in terms of survival advantage, no, but in terms of local control. Any other comments?
Well, thank you very much. In fact,
from Breast Cancer
Purit
Foundation.
cannot hear you.
Breast Cancer Foundation wants to talk to you.
Kamal sir, can I ask
Yes.
one question?
Yeah, please.
You mentioned that you want to know the depth of the tumor from the skin. According to we measure the depth of the tumor from the
Now
skin.
they're recommending that a booster therapy of 10 gray at least, if not 16, between that is recommended more and more. And I understand about the survival benefit issues because there are a lot of things we know, like mastectomy versus breast conserving surgery, nothing significant survival benefit. Axillary clearance don't give you any survival benefit. Radiotherapy on DCIs don't give you any survival benefit, but it reduces the rate of recurrence. Because when a cancer recurs, often it's invasive cancer and it's very difficult to manage because it involves the patient's quality of life, cost, and everything else. So survival is not the single denominator to decide a treatment plan. Thank you.
Okay, Farid. Yeah.
Kamal sir, you want to know the depth of the tumor from the skin. You know that according to ultrasound, we can measure the depth of the tumor from the skin, and according to histopathology, final histopathology report, also they can mention the tumor from the margin, 2 centimeter, 1 centimeter. So it can be measured from the pathology report and as well as ultrasound report. Not by my clip, right, sir?
Yeah, thank you. We were telling that we need to take the support from any imaging to know the depth that is helpful for our treatment. Okay, so there is another question I see, but this is the last one. Savila Salsabil, then we will move to our next session. Dr. Savila, can you please unmute yourself and ask the question?
Thank you for the nice presentation, Karthick. And I want to know about the use of humping block while using the detergent.
Sorry, your voice is not very clear.
You need to be more louder. She wants to know about the half beam block use.
Okay. Hello. Yeah. What's the question? Like, you want to.
I want to know about the use of humping block while using the detergent paste and what may be the disadvantage of using it and the benefits.
No, your voice is breaking. Sorry, I'm not able to hear properly.
Let me read her question. Do you routinely use half beam block while using tangent flares, and what may be the advantage and disadvantage of half beam block?
There's no disadvantage with the half beam block. Always there's an advantage with the half beam block. We always treat the breast cancers, whether it's a mastectomy or a lumpectomy, always we treat with a half beam block, which can avoid the divergence of the beam. Okay, so that half beam block is always an advantage. But it's not an open beam. Always we try to treat with the wedge fields. Okay, so that there is no disadvantage with the half beam block. Okay.
So thank you. I think we move to our next session. So as I was telling that we are still waiting for a volunteer who will make a small presentation of 5 minutes next week. And with that presentation, he or she will earn 10-point bonus. Okay, so now I need another volunteer for the case discussion. So may I have a volunteer? Please. Anybody? Other than Dr. Riyad. We need to hurry because we are running out of time. One volunteer, please. I see we have 60 participation. 61. Lima, can you help me to nominate somebody who will be volunteer?
Yeah. Now I can call by name. But
yes, please.
I'm a student. So where is Nusrat Haq? Where is Nusrat Haq? Nusrat Haq, are you there?
Madam, I'm there. Madam, I'm there.
So today you will be our
the volunteer. Okay,
yeah,
thank you, Lima. So a 30-year-old lady presented with a lump in her right breast. FNAC showed invasive ductal carcinoma. Ultrasonogram breast showed a 3 centimeter tumor in upper outer quadrant of right breast with right multiple axillary lymphadenopathy. Her mother is a breast cancer survivor for 10 years. What next? What do you want to do, Nusrat? She is in your chamber in front of you.
Address, that multiple lymphadenopathy, ultrasonography, family positive. What is next?
Yep. What investigation you want to do? FNAC was done.
Sir, I want to do core biopsy with
Very good.
ERPR
Very
HER2 status.
Yes, core biopsy from the mass of the done, and the FNAs from the node was done.
And FNAC from the node, yes, sir.
Yes, the core biopsy revealed it is an invasive ductal carcinoma grade 2, and FNAC of the node was positive. Unfortunately, the lady became triple negative, and Ki67 was 20%. We have done all the metastatic imaging, and there was no sign of any distant metastasis. Patient was placed to MDT. Now you are the convener of the MDT. So what will be your recommendation as the convener of the MDT? What do you want to offer this lady?
Sir, I want to see the previous slide, sir.
Okay, here it is.
Yes, negative, HER2 negative, that is triple negative. Metastatic imaging show no sign of any distant met. Sir, I want to go for neoadjuvant chemotherapy.
Very good. What protocol?
Sir,
it's a triple negative.
Triple negative, weekly AC followed by T.
Weekly or 2 weeks?
Dose dense, sir, dose dense.
2 weeks. Okay, thank you. So I know Farid may be talking about the platinum, but still we are following here AC and Texane.
AC Texane,
we
yes,
will
sir.
put a hydrogel marker implantation.
Yes, sir.
And then we will recommend after the neoadjuvant chemotherapy, breast conservation surgery. Then the question is whether we'll do a synthetic lymph node biopsy or axillary lymph node dissection.
Sir, we will go for axillary lymph node dissection.
Okay. And then we will give her adjuvant radiation.
Adjuvant radiotherapy. Yes, sir.
Very good. Now, what will be your recommended? Okay. So, and we have also asked for BRCA1 and BRCA2 mutation because her mother is a
positive, family history positive was,
and
sir.
her age is only
30.
Below 30.
Only 30,
so
yes, sir.
30. So, she's the ideal candidate.
For BRCA
so what
mutation.
will be the radiation therapy treatment recommendation for this lady? PMRT, PMRT or RNI, whole-based radiotherapy with RNI, whatever you want to do. Yeah, I know what you are looking at. Okay, what do you want to give?
RNI.
I mean, that is regional node irradiation. RNI is regional node.
The PMRT with RNI.
PMRT with RNI.
RNI, yes, sir.
We have done a BCS.
Oh.
We have done a breast conservation surgery.
Sir, but then we will go for a whole breast radiotherapy with node irradiation.
Regional node. Very
yes,
good.
Sir.
So we have the MDT agreed with you, recommended whole breast radiotherapy with RNI. So
yes,
what
sir.
will be the dose and techniques?
So dose will be 5,000 centigrade in 25 fraction.
Or 50 grade 25 fraction with boost 10 grain 5 fraction. Or 50 grade 25 fraction boost 16 grain 8 fraction. 42.5 gray in 16 fraction. And boost 16 gray in 8 fraction. Or there are so many.
Sir, I will go
Which
for
one you want to
50 gray 20 fraction with boost
25.
50 gray 25 fraction with boost 10 gray in 5 fraction.
Very good. Okay. But unfortunately, MDD went for hyperfractionated. 42.5 gray 16. 3D CRT boost 16 gray 8 fraction.
Yes, sir.
And because there are level 1 evidence that multiple randomized trial, they have shown that the hyperfraction could be a good recommendation to reduce the treatment time. provided what Karthik said, we need to take care of the cardiac dose and avoid cardiac toxicity.
Yes, sir.
Okay. So now the patient has a doctor attendant, and that doctor started asking many questions. So the lady is young.
Yes, sir.
Is it a contraindication for breast conservative therapy?
No, no
Number 2 is,
contraindication.
if TNVC a contraindication for breast conservation radiotherapy? Is family history is a contraindication? Whether BRCA positivity is a contraindication? The lady has a node positive situation, whether it is a contraindication. If she go for BCT, will it affect her survival, or she will go for mastectomy and go PMRT? And as it is a LABC, whether it is a contraindication for BCT. So we go one by one. So what do you think? Young age, is it a contraindication?
No, sir.
Okay, yes, the answer is no. There is a nice paper published in Red Journal, and they have shown that the women aged 20 to 49, and they have observed that the 10 years survival is comparable with mastectomy and BCS. So age is not a contraindication for breast conservation.
Breast conservation surgery. Yes, sir.
What about TNVC?
No, sir. This is not also a contraindication.
Good. So Annal of Surgical Oncology, there is a publication from MSKCC. They have shown 1,242 patients, and in every field, you see there is no difference in survival, but there is no difference in any field. Rather, they have shown that it is equally effective with mastectomy in early breast cancer. So we can say that TNVC is not a contraindication for breast conservation therapy. So now what about family history? She has a strong family history, whether it is a contraindication. It's a high-risk patient.
Not at all, sir.
Not at all. Very good. Okay. So this is a publication, Acta Oncologica. They have seen a series of 1,100 ladies, and they have shown that family history is not a contraindication, and rather positive family history in their series has done better with breast conservation surgery and radiotherapy. So the last three, so BRCA positivity, is it a contraindication?
No, sir.
No, it is also no. So the last three questions, node positive or LABC, all these things, will it be offering less survival compared to mastectomy?
No, sir.
PMRT? No. Okay, there are many trials showing that the survival is the same, it is not inferior, but in some series we have seen that the recurrence is slightly higher in breast conservation series, but not all patients, especially high risk and younger. But there are some papers, even this is a MD Anderson, they have shown that the survival is better with breast conservation therapy. Okay. So this is a paper review article published in 2017, and they have gone through all the data and they have concluded that BCT is equally effective with mastectomy for survival. In some series, there is a risk of recurrence slightly higher, but it is not statistically significant. But we need to discuss it when we discuss with the patient. Okay, now the patient has completed the neoadjuvant chemotherapy, and there was a complete radiological response because it was a triple negative, and breast conservation surgery and axillary lymph node dissection was done, and the staging report is PT1 1 centimeter, N0 M0 with 0.1 centimeter margin. My question is, do you accept this staging report or pathology report? Are you happy with this report?
No, sir.
Why?
Because the positive or close margin is 0.1 centimeter for invasive breast cancer.
No, I am asking that this report, is it okay? There is a, okay, tricky. we should put a Y because there
sir,
is a NSCT.
NSCT YP, yes sir. After
So
NSCT,
it should be
phase
T1, not T0.
T0.
Okay.
Yes, sir.
So if it is YP T1,
Yes,
N0,
0.
0.1 centimeter margin, at this situation, will you offer her radiotherapy? With this, not this. Because it is a very good response. Patient is telling that tumor is gone, kichu nai, sob chole geche. Why to give radiotherapy?
স্যার আমি কোশ্চেনটা বুঝিনি, এটা কি আমার ফ্রেশ কেস নাকি নিউ অ্যাডজুভেন্ট কেমোথেরাপির পরে?
এই সিচুয়েশনে will you give radiotherapy or not?
Sir, if it is fresh case, then I will go no radiotherapy.
After neoadjuvant therapy. And if it is
after neoadjuvant therapy,
response, will you give radiotherapy?
Yes, sir.
Okay, so I think what is a good margin? Actually, after neoadjuvant, even it is a complete pathological response in whole breast radiotherapy, there is still we need to give radiotherapy. We cannot still avoid it.
Yes,
and regarding the margin, previously we had a big debate of what is the margin. Then now say that no tumor on ink is the issue, but it is not applicable in DCIS and APBI and patient treated with neoadjuvant chemotherapy.
Chemotherapy, yes, sir.
So now I think we can skip this because we are running short of time. Okay, coming to RT planning. So what are the 2D border for whole breast radiotherapy? It was told by Karthick. Can you please just quickly recapitulate?
Sir, upper border, second intercostal SSN or second rib, and 2 centimeter below the inframammary line. Medial is 1 centimeter from the midline or midline, and lateral border is mid-axillary line or to cover the breast tissue.
Very good. You know much better than me. But thing is that, yeah, normally for the lateral border, we need to examine the breast tissue.
Yes,
because mid-axillary line is some surrogate, but it should not be always considered. Sometimes it may mislead us.
Yes,
we need to examine the breast tissue, then we need to take some margin. As Karthik was telling, we need to consider about the penumbra and also the setup error. In 2D era, we need to treat sometimes a bigger field because we cannot miss the target. That is important.
Yes, sir.
So if it is a 3D, so do we need a contouring guideline? Why we need a contouring guideline? Okay, let me help you. Because now the era is 3D.
Yes,
newer technique, better conformity and lower toxicity.
Yes, sir.
But we need to have accurate identification of clinical target volume. It is now necessary. And we need to reduce the inter-observer variation. Look at this.
Yes,
many qualified oncologists has contoured, and how much difference is there on the margin. So even the qualified oncologists, they have inter-observer variability. When you follow a guideline, this inter-observer variability becomes very less. So that is the reason that why we should follow a contouring guideline.
Contouring guideline, yes, sir.
So these are the bony anatomical landmark we need to know, that the sternum, breast, this muscle and serratus anterior.
Yes, sir.
What one this?
Latissimus.
Yes, latissimus dorsi.
Latissimus dorsi.
And what about this?
Scapula.
Okay, good. So now the RTOG guideline, how they are telling, before planning, we need to mark, as Karthik said, the base of the breast and the scar.
Yes, sir.
And cranially, secondary insertion, caudally,
yes,
loss of breast tissue, apparent breast tissue.
Yes, sir.
Posteriorly, breast, exclude pectoralis muscle, chest wall muscles, ribs. But when it is stage 3A, include pectoralis muscle and chest wall. Anteriorly, it is the skin. Medially, sternal rib. And laterally, clinical reference and mid-axillary line typically exclude latissimus dorsi muscle. This is the recommendation of RTOG, which was published in 2009. But ISRO has published a recent guideline on vessel-based contouring, which gives a smaller volume than RTOG. So posteriorly, the skin and subcutaneous tissue to the anterior surface of the pectoralis major only recommends inclusion of the pectoralis major and rib in the setting of documented invasion of T4A or T4C, anterior 4 mm under the skin. Medial lateral to the medial perforating mammary vessel, maximally to the edge of the sternal bone. Guided by palpable visible sign, if appropriate, guided by the contralateral breast. Laterally, lateral breast fold, anterior to the lateral thoracic artery. So they are always taking some vessels to guide you the extension.
Yes, sir.
So the question is, which is better? Let us forget John is here, Farid is here, and Zakir Bhai is here. America or Europe? So there is a nice paper published in 2017 in Radiation and Radiotherapy and Oncology. They have done a three-dimensional analysis. It's a Korean group, and they have shown for the whole breast radiotherapy, the majority of the recurrence is within the volume, and 96% is there. So for BCT, the smaller volume is CTV guideline is fair enough when we are considering only the whole breast radiotherapy. But what about the future? This is a Red Journal publication in 2019. That is interesting. They have shown the recurrence is not only related to the contouring, but also related to the tumor biology. So the time may come, like the AJCC 7th and 8th, we will be considering the dose and distribution and volume on the basis of the tumor biology, maybe in breast in near future. So now I am showing you two pictures, Nusrat.
Yes, sir.
This one and this one. Which one you will like to select for a
my right one?
This one or this one?
Sir, opposite. Dan digetta, sir.
This one?
Yes, sir.
Why? It looks nice.
Sir, lung dose is less there.
How? Look, here is a divergence. So this beam goes like this, and sorry, and this beam go like this. But when this is the same plane, so
yes,
no
sir.
divergence. So this is
Yes,
type of half beam block effect.
Yes, sir.
So here you're blocking the whole thing. So the no remaining lung is getting any dose. That's why it is very important. And Karthick has shown in his planning that we need to avoid this divergence.
Yes, sir.
So how much lung volume we should take?
How much lung volume?
Today planning.
To this central lung dose should be less than 2 centimeter.
Yes.
But within
this
2
is
centimeter.
This is the slide that Karthick have shown. But what
yes,
I want to show that how we are measuring it.
Yes, sir.
You see, now how we are measuring from here to this is the lung, and when it is the heart, then we need to consider the heart also.
Yes, sir.
So there are some tips of contouring. I'm going very fast. The slide will be provided, so I'm not going to cover there. Will you take the chest wall in the CTV for whole breast radiotherapy, Mr.? We are almost at the end.
No, sir.
Okay, let's see. Case 1, T1C N0M0. Yes, you are correct. We are not taking the chest wall. Now the case 2, stage 3A, T2N2.
Yes, sir.
Here you see then, in the contouring, we are taking the chest wall.
Pectoralis, yes, sir. In case of stage 3, when the tumor is stage 3, then we will
take the chest wall. But when it is only pure breast, you can avoid it. You don't need to take it.
Yes, sir.
Okay. We already discussed about the cardiotoxicity issue, 7.4% increased major coronary events for only 1 gray of mean dose radiation to the heart. So this is how we can avoid. So now it's almost the end. This is the data I have collected 3 years back. In the developed world, 70% of the breast cancer patients received breast conservation radiotherapy. In India, it was 30%. And I collected information from many centers in Bangladesh, and it came that 5% of the breast cancer patient is getting whole Cancer Institute and United. So I had a very embarrassing experience when I was in training at UPMC. I was asking my senior colleague that I want to learn post-mastectomy radiotherapy. And he tried to find out many cases, and at the end of the day, he gave me a mail chest and say, okay, now you start planning on it because I don't have a post-mastectomy radiotherapy patient. So in 2010, he could not find a post-mastectomy patient. But unfortunately, till there, I have never treated a patient with whole breast radiotherapy. That was our experience because we didn't have LINAC and we have many limitations. Yeah. So this is the Stephen Hawking said, the greatest enemy of knowledge is not ignorance. It is the illusion of knowledge. So whatever we know, we need to know very properly. So thank you, Nusrat. It was wonderful and you have done very good. At your age, what you are telling, I didn't knew what you said.
Thank you, sir.
Lima, unmute yourself if you want to make a comment. Lima, unmute yourself.
Yeah, I'm audible?
Yeah, please.
Yeah. So this type of case scenario, this patient is 30 or 35, no?
30 years.
30 years. And suppose she is BRCA1 positive and underwent BCT, and the patient is affordable. And she is very conscious about the modern technology. She wants to have IMRT. So my question to Karthick, for this patient, do you consider for inverse plan IMRT with this BRCA1 positive patient, young patient with multiple fields?
Karthick.
Hi. Okay, like you know, see, like breast IMRT is really it's a challenging one. Okay, and still it's possible. Like you know, it's not possible. We have done some patient as you know, as we are in private hospital. We have done a lot of IMRTs in breast. Like we can try, but you know, we need to be careful. Like you know, how we do it. Like normally for every field, we try to give a skin flash distance of somewhere around 1 to 1.5 centimeters in IMRT field. So that these things we need to be very carefully handled so that you know we don't you get a very homogeneous distribution and your entire respiratory motion is a big issue like when you do IMRT. Okay, like you know during respiration the breast moves up and down so that you need to have a clearance for that. So that this thing needs to be considered when you do an IMRT. Yeah, it can be possible you can do IMRT.
So one thing we should consider for this patient as far my knowledge concerned, as she is BRCA1 positive, and BRCA1 positivity is very sensitive to radiation. So her opposite breast is also very sensitive of exposure of low grade of radiation. So if we use the IMRT with multiple beams that pass through the opposite breast, so she is increase the chance of the second malignancy in the opposite breast. So in this case, it is wise to advise avoid the IMRT inverse plan, and we can consider some field-in-field technique or forward plan IMRT for the breast. So inverse plan IMRT is not considered for this patient.
Yeah, see, the difference.
Thank you, Lima. It was quite educational. I mean, forward plan IM is the most popular for breast than inverse plan, but still people are doing for VMAT. And what you said, yes, unrelated breast is a big issue here when it's a BRCA1.
Yes,
so we are running short of time. Can you please, Regan, put the link for the quiz?
Who's that?
Please. For it. Yeah, link is there for the quiz.
All right, can I?
Yeah, please.
Can I apologize? I'm afraid I have to leave. And the case scenarios and the discussions. I don't want to leave, but I have to go. And if I leave early, I think I would be forgiven. Can I seek permission to leave?
Oh, please, you can.
Thank you for
sir.
it. Thank you for your time.
Thank you, Karthick.
And take preparation for your next lecture.
I'm doing it.
Okay, thank you.
Sir,
Thank you.
sir, before leaving, please answer this question of axillary marker.
This we will put in the post-mastectomy. We have more session there.
We'll do that later on, Nafisa.
Later on.
Okay.
Okay. Assalamu alaikum.
Okay, bye. Walaikum salam.
Regan, get ready to give the. Okay. Analysis of the last session after this.
বুঝি না এটা কি হইছে কিছুক্ষণ না এটা অন্য ইয়ে চলতেছে
So less than 1 minute to go. Sorry, less than 2 minutes to go. So we need another volunteer for the rapid fire session. If no volunteer, then somebody can utter the name. So Lima or Asma, Dr. Asma can nominate somebody for Lubna.
You should nominate another lady doctor.
Yes, why not?
I think they should come forward.
Okay, Regan, তুমি তোমার এটা করে নাও, রেজাল্টটা তারপর এটা করব। আমরা এটা করে নেই, আগে র্যাপিড ফায়ারটা করে নিই।
So I think here is Noshin is there. Noshin, was it my senior Eva Tohinda?
Anybody volunteer first, then otherwise they will call the name.
Can I see the names of the doctor from where I can see?
Go to the participants.
Participant.
Click participant.
Participants. কামালউদ্দিনই তো দেখতে পাচ্ছি আসমান সিদ্দিকী সাদের কোথায় আছে
So any volunteer?
Most of them are very junior person.
Oh what? Juniors are the
They are just
driving
part one aimed students. I think they'll not be so much.
Just for fun.
কোথায়? Okay, you can choose Dr. Debraj also.
Okay, Debraj, you are chosen by your madam.
আমি নিজেও স্যার আমার নামটা দিয়েছি
Okay, good, very good.
Thank you, sir.
Am I
Okay, so
disqualified for
can we
today?
treat whole breast radiotherapy with cobalt?
Yes, sir.
Yes. What is the limitation? If we
Limitation-
treat with the cobalt, what will be the limitation? What we need to consider when we are treating a patient with the cobalt whole breast radiotherapy? What is the energy of cobalt?
Energy deviation is there.
What is the energy of cobalt?
Cobalt, sir, 1.25, sir.
So the separation is the issue. We can comfortably treat a patient if it is a lean and thin, but if it's a big breast, the separation is big, then it will be a big issue.
Yes, sir.
And another problem is the boost. Normally, whenever the center in India, they use cobalt, but they use electron for the boost. Normally, they don't recommend to give the boost with cobalt. So what percent of early breast cancer are eligible for breast cancer radiotherapy? What do you think, Debraj? Just a wild guess.
Like 60-70%.
60-70%. It is more. 75 to 80% is a candidate for breast conservative therapy. Which data supports equivalence of BCT with mastectomy in survival?
I don't know the name.
Which
sir.
trial?
RTOG trial, sir.
RTOG trial. Very intelligent answer. At least you will cover a big area. Good. So 7 randomized trial, but in breast, always tell NSABP. It will cover something, not RTOG. NSABP is B6, Milan 3, Royal Marsden, URT is 10801. This is the trial. They have shown that the survival is equal. And what data supports the hypofractionation in whole breast radiotherapy? We have discussed a long today about hypofractionation. Okay. Canadian trial. Start A
That
and
is
B.
the RMP, start A, start B Canadian, sir.
Very good. Very good. So, what data supports the tumor bed boost? You should tell it, Debraj. The landmark trial. Boost trial, always tell 2 trial. Always think of France when you think of boost. Lyon boost trial is a very landmark trial, and this URTC boost trial. So is there any need for higher tumor boost in incomplete excision in breast conservation surgery? Say there is a micro positivity after excision. Will you give a higher dose to the boost cavity or the same?
Same, sir.
Same. Why?
Sorry, sir.
Why? Your answer is correct.
Yes.
Because the URTC boost trial have shown that 251 patient. Hello.
Yes, sir. You're audible, sir.
Hello.
Dr. Asma
Hello. Yeah.
You're audible.
Can
sir.
you hear me, please?
Yes, sir. We can hear you, sir.
So the URTC. URTC boost trial have shown 251 patients with microscopic incomplete resection margin. They have randomized in 10 gray and 26 gray and made a follow-up of 11.3 years. There was no difference on local control or survival. So that's why there is no need of additional higher dose, even there is a microscopic positivity in boost cavity. So what is the target of your boost radiotherapy, Debraj? What do you want to target when you are giving a boost? Scar?
The tumor cavity.
Sorry?
Tumor cavity, and if there is any serum around it.
Which cavity? I cannot hear you.
Tumor cavity.
Tumor cavity. Yeah. Normally we say so cerebral cavity, and depth is the important factor because we need to know the depth to identify the electron energy, what Karthik said, because depth is the guidance which will help us to identify what will be the ideal electron energy that we will treat. What is EIC, Debraj? Extensive intraductal component. What does it mean?
Breast cancer where there is a component of the cancer cells in the inside the duct, sir.
Okay, that is not this. This is DCIS, both mixed and adjacent to invasive disease, and comprising more than 25% of the total tumor mass. From studies, mainly from JCRT, EIC is only prognostic for local failure if marginal status is considered. If there is a close or positive margin, EIC is associated with higher risk of recurrence. So, next question is, will you use
And here, sir. Please bolus in you.
Yes, you will use a bolus.
If there is skin infiltration, then yes, sir.
You will have a bad time. The patient is probably sorry.
There's so much noise, sir.
Will you use or not?
I will use if there is skin infiltration, otherwise not, sir. No, sir. No, sir.
So, no, normally we don't recommend bolus because if you put a bolus, it will not ruin the life of the patient, it will ruin life of you also. Because there will be so much toxicity on the skin, the patient will be safe from disease, but die from the toxicity, probably. Okay, now just relevant question. If when your whole breast radiotherapy is given, the whole breast, which area you will be looking for the hot spot? I mean, what you will tell to the patient that please take care of this part. এই জায়গাটায় problem হতে পারে. The most common site of skin reaction কোথায় হতে পারে? Any idea?
Complex, sir.
It is at the lower mammary.
Oh, it's intermammary fold, sir.
Okay. What data suggests that result of BCT can be further improved with use of tamoxifen? Which trial have proven? NSCBP 21. Okay. So that's all. Thank you, Debraj.
Yes, sir.
Okay, very quickly, we want to see the last week analysis. Shadat, Regan. So last week, we had a session on adjuvant chemotherapy, and our speaker was Dr. Shahida Alam. Next slide. Regan. So we sent invitation, close invitation 72, participants 73, 23 participated in the quiz, and 7 participated in the feedback. Next slide. Sharif, Dr. Sharif Ahmed, junior consultant, was the winner. Next slide. So highest score was 90, and 8 made this 80 to 100%, 10, 50 to 70, 5, 20 to 40. So when you have the same score, fastest person get the award. Next slide. So you can see that gradually there was a rise in invitation participants, slightly fall, quiz rise, but feedback, we have a fall here. We need more feedback from you. Please try to respond to our feedback questionnaire. It is very important. It helps us for our next session design. Next. Thank you. So coming back to
about the today's result.
So today's result, before, but because we have seen, once we declare the result, everybody leaves. So today we are keeping it pending. Okay. So today we want to thank our scientific partner, Sanofi Aventis, for supporting us, and also our foreign faculties for giving us time. And we are, sorry, next week our presentation will be how shall we treat triple negative breast cancer from the current standard to future possibilities. Our speaker will be Dr. Rudrangshu Dash, and we are expecting all the 3 foreign faculties to be there. And in the list of the upcoming items, we have added a new item. How can you keep your data? Dr. Zakirullah agreed to make a presentation in the coming days for the young juniors, that how can they start keeping their own data, which will be helpful for their future career development as a researcher. So this is almost at the end. Now I think we can declare the winner.
Can I say one thing?
Sir.
Okay.
Zakir bhai.
Just to tell you, I mean, John, are you free next week to join?
I might not be here next weekend. I'm on holiday, on annual leave, I'm afraid. So we might have to find a friendly replacement.
I've just spoken to Peter Schmidt. He is the world authority on triple negative cancer. He just said that he will join.
Great. Thank you very much. So, John, have a nice holiday, but subsequent week we want you there.
Okay.
We have developed a habit of having you here every week.
No, he's very supportive. John is always very supportive.
So nice of him. So John, before we end, you have heard the whole lecture. We have a limitation of technology and you don't have Linux everywhere, but now we are trying to move from mastectomy to breast conservation. So breast conservation radiotherapy is a upcoming thing. So do you have any comments on the whole session?
I thought the presentation was fantastic. I think in anything in medicine, it's important that you remember the fundamental principles. And once you know the basics, you can then extend your knowledge into more advanced treatment techniques, diving in, looking at 3D conformal IMRT, etc. I think that's all fine, but actually understanding the core principles, what is your CTV, what's your PTV, how do you define your target volume? If you can get the fundamental principles right, you're on the road to success for you and your patients. So that's important. Great talk, I have to say, really good.
Thank you. Thank you, John.
Can I add one more line? Sorry to say, I mean, you'll probably be interested. In Bangladesh, I've seen more than 40% or 50% cancers are triple negative. We don't know why, whether this is a specimen problem or I think quite a lot, don't you think? Shahida was not.
20 to 25%. I think I have 300 patient data. It's around 20 to 25%.
Okay, because I saw another one
Still it is high.
About 40%.
Still it is high.
It's much more than what we normally quote internationally. So if you Google this Professor Schmid, Peter Schmid, SCHMID, he has why I'm saying he's a world famous triple negative lead, and he has many publications, especially immunotherapies and other things. So if we give him a little bit of time, maybe 10 minutes for his thing at one point, that will probably help.
We will be happy to hear from him. Just tell him that how much time he needs.
Thank you.
Okay.
10 minutes.
Thank you, Zakir bhai.
Thank you.
So now our today's winner. Our today's winner is Dr. Altaf Hossein Riyad. He has scored 70 out of 100 and his required time was 3.5 minutes. So 3 minutes 50 seconds, sorry, 3 minutes 50 seconds. So you see, even we disqualified Riyad from the hot seat and the rapid fire, but he kept his tendency of winning something. So he had moved to quiz. So congratulations, Riyad.
Thank you,
He
sir.
deserves
Thank you.
it. No, he deserves
Thank you,
it.
sir.
Yeah, he deserves it. So with this, I think we can end today's session, sir, if I'm allowed.
Already high time. We have already taken 25 minutes.
Yeah,
more.
we have taken a bit higher time, but it was important because sir, breast conservation radiotherapy is something very important for very commonly exposed to it. Many of us in our early life. So small things need to be cleared. So we had a good discussion, and I think we all enjoyed.
Yes.
So thank you very much. So see you next week. We will be talking on TNBC.